हेलो दोस्तों, स्वागत है आपका आपके अपने YouTube चैनल लैब शिक्षा में। तो आज हम BMLT थर्ड ईयर हेमाटोलॉजी सब्जेक्ट 2020 पेपर को सॉल्व करने कर रहे हैं। 2 मार्क्स 1 क्रॉनिक माइलोइड ल्यूकीमिया CML ऑल्सो कॉल्ड क्रॉनिक माइलोजेनियस और क्रॉनिक माइलोसिटिक ल्यूकीमिया CGL कॉमन इन मिडिल एज ग्रुप characterized by presence of marked increase in series of myelocytic series, predominant cells, neutrophils, myelocytes and metamyelocytes. TLC is generally higher than 50,000 to 200,000 per microliter. 2. Causes of microcytic hypochromic anemia. A. Iron deficiency due to blood loss, improper gastrointestinal absorption, excess demand. B. Miscellaneous such as lead poisoning, thalassemia. 3. Bone marrow examination. Indications: unexplained anemia, leukemia, lymphoma, myeloma, pancytopenia, staging of malignancy or diagnosis of storage diseases. Contraindications: severe bleeding disorders like hemophilia, local infection at puncture site or severe thrombocytopenia without supportive care. Exam tip: should be done with caution in very ill or unstable patients. 4. Direct versus indirect Coombs test. Direct Coombs test DAT detects antibodies or complement directly attached to red blood cells. Useful in autoimmune hemolytic anemia, hemolytic disease of newborn, HDN and transfusion reactions. Indirect Coombs test IAT detects free AB present in patient's serum against red cell antigens. Commonly used in cross-matching before transfusion and antenatal screening. 5. Romanwski stains, routinely used for staining peripheral blood smears and malaria smears. Provide good contrast between blood cells and parasites. Examples: Leishman, Giemsa, Wright, Fields. Components: methylene blue, basic dye, eosin/azure, acidic dye. Help to identify red cells, white cells, platelets, and malarial parasite clearly, making them essential for hematological and parasitological diagnosis. 6. Red Cell Indices MCV mean corpuscular volume 80 to 100 femtoliters. MCH mean corpuscular hemoglobin 27 to 32 picograms. MCHC mean corpuscular hemoglobin concentration 32 to 36 grams per deciliter. These indices help to classify anemia as microcytic, normocytic or macrocytic and guide further investigations. 7. LE cell test. Blood test to detect LE cell, helping diagnose systemic lupus erythematosus SLE. Mechanism: neutrophils engulf denatured nuclear material forming LE cells, largely replaced by ANA and anti-dsDNA tests now. 8. Reticulocyte count measures immature RBC in blood, indicating bone marrow activity. Useful in anemia evaluation and monitoring response to therapy. Normal range 0.5 to 1.5%. Increased in hemolysis/blood loss. Decreased in marrow failure or aplastic anemia. 9. Flowcytometry technique for analyzing physical and chemical properties of cells in suspension. Cells are passed through a laser beam and labeled with fluorescent markers. Uses: immunophenotyping in leukemia, lymphoma, detection of CD markers, DNA analysis or apoptosis. 10 marks. 1. Classification of anemia. Morphological classification based on RBC indices. Microcytic less than 80 femtoliters. Iron deficiency, thalassemia, sideroblastic anemia. Normocytic 80 to 100 femtoliters. Aplastic anemia, chronic disease/inflammation, acute blood loss. Macrocytic greater than 100 femtoliters. Vitamin B12 deficiency, folate deficiency, liver disease. Expert exam tip: remember MCV ranges for quick diagnosis. Etiological classification based on cause: blood loss, acute, trauma/surgery versus chronic, GI bleeding, heavy menstruation. Deficient RBC production: nutritional, iron, B12, folate. Bone marrow failure, aplastic anemia, myelodysplasia. Chronic disease/endocrine, renal, liver, thyroid. Increased RBC destruction, hemolysis, hereditary, sickle cell, thalassemia, G6PD, acquired, autoimmune, mechanical trauma, infections like malaria, megaloblastic anemia, laboratory diagnosis. 1. Complete hemogram, decrease in Hb concentration, red cell and PCV. MCV, increase more than 92 femtoliters. MCH, decreased less than 27 picograms. MCHC, normal or decreases less than 32%. Reticulocyte, normal or less. 2. Peripheral blood smear, large number of macrocytes. Anisocytosis, variation in cell size. Poikilocytosis, abnormality in cell shape. Megaloblasts, moderate leukopenia and mild thrombocytopenia. 3. Bone marrow examination, hypercellular BM with megaloblastic erythropoiesis, increased in reticulum cells, macropolycytes present, myeloid to erythroid ratio reduced. 4. Biochemical test, serum total bilirubin and indirect bilirubin moderately elevated, urine urobilinogen increase, serum vitamin B12 normal 160 to 925 picograms decrease, red cell vitamin B12 normal 70 to 512 nanograms per liter decrease. 5. Other investigations, serum and red cell folate decrease, assay of intrinsic factor in gastric juice, detection of parietal cell antibodies. Expert tip, check both serum and red cell levels. Expert exam tip, differentiate B12 versus folate with these tests. 2. Causes of leukocytosis and leukopenia. Causes of leukocytosis, WBC greater than 11,000 per cubic millimeter. Infection, bacterial, pneumonia, sepsis, parasitic, fungal. Inflammation, rheumatoid arthritis, IBD, vasculitis. Hematologic disorders, leukemia, myeloproliferative diseases, CML, polycythemia vera. Physiological, exercise, pregnancy, stress. Drugs, corticosteroids, lithium. Tissue damage, burns, trauma, surgery, MI. Allergy and asthma, eosinophilia. Causes of leukopenia, WBC less than 4,000 per cubic millimeter. Bone marrow failure, aplastic anemia, radiation, chemotherapy. Infections, viral, HIV, influenza, hepatitis, measles, dengue, typhoid. Autoimmune diseases, SLE, rheumatoid arthritis. Drugs, cytotoxic agents, chloramphenicol, anti-thyroid drugs. Nutritional deficiency, vitamin B12, folate deficiency. Hypersplenism, increased destruction in enlarged spleen. Hematological malignancies, leukemia, lymphoma, marrow infiltration. Leukemia reaction, a temporary and excessive increase in WBC, usually more than 50,000 per cubic millimeter. Looks like leukemia but is not cancer. It is temporary and disappears once the cause is removed. Causes, severe infections, tuberculosis, sepsis, pneumonia. Severe hemolysis, tissue necrosis, burns, trauma. Certain drugs, corticosteroids. Differentiation versus CML, leukemia reaction, high LAP score, CML, low LAP score. LAP equals leukocyte alkaline phosphatase, crucial differentiator. 3. Special/cytochemical stains in hemolytic anemia. Hemolytic anemia occurs due to increased RBC destruction. Stains detect abnormal inclusions, HB defects or enzyme deficiencies. 1. Cytochemical, provide direct visual evidence of hemolysis/cause, differentiate intrinsic versus extrinsic. 2. Supravital, new methylene blue, brilliant crescent blue, used for reticulocyte count, precipitated ribosomal RNA as blue networks. Increased equals BM response. 3. Heinz body preparation. Supravital stains show denatured HB aggregates, seen in G6PD def, unstable HB, oxidative stress. 4. Prussian blue, pearl stain, demonstrates iron deposits in RBC/BM, detects Pappenheimer bodies, differentiates from iron deficiency anemia. 5. Romanwski, Wright-Giemsa, Leishman, Fields. Identifies RBC inclusions, Howell-Jolly bodies, nuclear remnants, and basophilic stippling, RNA aggregates, thalassemia, lead poisoning. 6. Enzyme cytochemical, detect RBC enzyme def, G6PD, pyruvate kinase showing reduced activity. Tip: reticulocyte count is key for BM response assessment. 4. Laboratory diagnosis of hemolytic anemia flowchart. Step 1. Confirmation of hemolysis. Biochemical: increased unconjugated bilirubin, increased LDH, decreased/absent haptoglobin. Urine: positive hemoglobinuria, urobilinogen. CBC, HB, decreased HCT. Reticulocyte, increased. Step 2. Peripheral blood smear morphology. Spherocytes implies suspect AIHA/hereditary. Schistocytes implies suspect MAHA, TTP, DIC. Sickle cells arrow suspect sickle cell. Target cells arrow thalassemia. Bite cells/Heinz bodies arrow G6PD. Step 3. Determining etiology. DAT positive plus arrow immune hemolytic anemia AIHA, IgG, C3, warm/cold. DAT negative minus leads to non-immune. Specific tests: HB electrophoresis, osmotic fragility, G6PD assay, Flowcytometry. Tip: reticulocyte count is key for BM response assessment. Always correlate PBS with clinical history. Don't forget family history for hereditary causes. 5. Platelet disorders, causes and counting methods. Thrombocytosis, increased platelets greater than 450 times 10 to the power of 9 per liter. Reactive, secondary, infection, inflammation, RA, SLE, IBD, tissue damage, malignancy, iron deficiency anemia, hemolytic anemia, post-splenectomy, smoking, medications. Primary, clonal, essential thrombocythemia, polycythemia vera, primary myelofibrosis, CML. Thrombocytopenia, decreased platelets less than 150 times 10 to the 9th per liter. Decreased production, BM failure, chemo, drugs, viral, alcohol, nutritional, B12. Increased destruction, ITP, drugs, infections, autoimmune, alloimmune, DIC, TTP/HUS. Sequestration, hypersplenism, dilutional, massive transfusion. Method for platelet count, automated, impedance principle or optical/flow cytometry. Specimen, whole blood in EDTA 2 to 4 hours. Manual, Reese echo chamber/improved Nuba using diluting fluid. Normal range, 150 to 450 times 10 to the 9th per liter, 150,000 to 450,000 per microliter. Tip: platelet count is key for bleeding risk assessment. Correlate with peripheral smear.